Okay, good afternoon everyone. We are running a little late in time, so I'll quickly wrap this up and let Madam had the final word on things. So, mid-phase reconstruction, I've titled it Embracing the Heterogeneity. So, what I mean by the title is it's a very heterogeneous group of defects. Now, maxillectomy with no reconstruction across small to big to large is a very variable set. But the common uniting theme is all of it has a very poor cosmetic outcome. I think probably the reason is because of the contrast provided by the lower mandible below and the upper face. But it need not be so. Like this patient who underwent a total maxillectomy, and this is 1 year post radiation follow up. And we had put a lot of bone in him, a central segment, lateral part of bone, orbital floor, nasal lining, and a palatal lining. So let's see how we go about it. So the first thing we need to appreciate is that the anatomy of the maxilla. Unlike a mandible, it's not that linear. There is a body of mandible maxilla with a sinus at the center. There are 4 processes: the zygoma, zygomatic, alveolar, palatine, and frontal, and there are 6 walls, each of which is opposed to a different structure. The superior to the floor of orbit, inferior to the palate and alveolus, medial to the lateral nasal wall, lateral to the cheek, anterior also to the cheek, and posterior to the skull base. What is given is you can understand that when the anatomy is so complex, so would be the functional and cosmetic implications. Now, first order of thing is you need to understand the etiology of these things. Whenever you are dealing with a squamous cell carcinoma, the margins will be different. The amount of the prognosis might be different. A lot of these patients would now be COVID related, and occasionally you are dealing with primary bone tumors or mucosal sinus origin tumors. So in the primary bone tumors, you have time in your hand to do the reconstruction, plus osseointegration is a good likelihood, and that should be the end point of your aim. Now, how do you understand these defects? Now, given the heterogeneity, there is a list of systems which have been described for classifying the maxillar defects. I can't even read them out. All of them has their pros and cons. So communication itself is a little tricky. I would recommend the Brown and Shaw system for classification. I find this is the most simplest to understand the defect. Reconstruction choices, I will talk about how to do that later. So when you look at the Brown and Shaw classification, they have simplified it. You look at it in 2 terms, a horizontal element and a vertical element. So the vertical element, grade 1 is when it's just alveolectomy. Grade 2 is when it's a little larger and the sinus is open. Grade 3 is when floor is breached. Grade 4 is when orbital exentration is done. Grade 5 is when no dentition is, alveolus is not disturbed, it's a supraalveolar defect. And grade 6 is proper mid-face defects. The horizontal elements, 8, A is palatal fenestration, B is lateral defect not involving premaxilla, C is only premaxilla, and D is a combination of B and C. So it's a very basic schema, but it has its problems. So when you look at the mid-face, what you are trying to achieve in reconstruction is first the facial appearance. Main is cosmesis. You need symmetry, good contour, minimal scars, and the biggest problem, lid position and eyeball support. You need to create a barrier between the oral and sinonasal cavities, and if the defect is higher, between the sinonasal and anterior cranial fossa. Then you need to support 2 structures, orbital contents for sure, and teeth hopefully. All of this results in maintenance of speech, oral continence, and patent nasal airways. So now Brown and Shaw gave some reconstructive options. Like for the small lesions, they recommended a radial. For mainly bulky lesions, an ALT, rectus, or LD. And for bony lesions, they have recommended a mixture of fibula, DCIA, scapula, and radius. Now the problem, if you have to critique this whole system of Brown and Shaw classification is, we see a different type of patients. Our defects are much larger. Often our defects are extending bilaterally into both maxillas, a combination of central and lateral. The soft tissue defects are much more. There is no measure of the soft tissue defect and the skin thickness or skin excision. Apart from that, you often see our defects are combined with a soft palate uvular defects, or there is a coexistent buccal mucosa defect, there is a zygoma, and sometimes it even extends to a part of mandibulectomy and lip also being involved. And in their recommendations, they have not really taken into account the donor site variability in terms of skin and soft tissue thickness. So my take on this is you again go back to this trilogy of defect, donor site and design and think of it as a very basic level, tissue element wise, that what you want to reconstruct. So now if you look at it, for the bone, this is the maximum possible elements you might need for reconstruction, right, central or left. For the orbital floor, basically the floor, laterally the medial, rarely the medial or lateral walls. For the mucosal lining, palatal lining, often you will need, rarely the mucosal, and optionally if possible the nasal lining, and skin and filler as needed. And another important thing is, with all the sinus cavities being open, skin flaps being thin, there is a larger soft tissue defect. So in a grand strategy, what are your options and how do you proceed? So for very small defects or very large defects, you go for only soft tissue, or occasionally combined with a non-vascularized bone. For this very small central palatal fenestration or lateral defect, you can go for prosthesis obturator based. Everything in between is better served with a vascularized bone, usually fibula, rarely you can go to scapula angle. So this is what we generally end up using at TMH. When you need only a skin filler, we need a radial or a MSAP. For the larger defects, generally an ALT, very rarely you can use a DA rectus or an LD. And for bone, mostly fibula, very rarely a scapula. I'll just talk about prosthetic rehabilitation first. So this can come in different forms. Simplest of them is obturator, and sometimes when along with a skin defect, you can mount it with a prosthesis also. There are two criteria for this. You need a good remnant dentition to hold it, and you need the mouth opening to be good. Best indications are small lateral pure palatal defects, grade 1 or 2 or 1C defects. And this also comes into play when you have a failure or salvage situation. It can give you exceptional results with the right expertise. So this was one patient where we lost the fibula and used an obturator with mounted teeth. This is another lady where again we had a failure and issues with the flaps, so we used an obturator with a mounted prosthesis. Now next is when do you use only soft tissue reconstruction? So as I said, either too small or too large. So this was a young girl with a lateral defect. We used a radial artery forearm flap. Concerns with the donor site. Next patient, we used an MSAP in this girl. Now this is the other end of spectrum, where the defect is so overwhelming that a fibula will not suffice. Even a soft tissue flap required will be much larger. More than anything, you can't make a very long plan or complex plan here, because these are the patients who might not do very well in long term. So this was a large ALT fill dip. Even the orbital floor was used with a sling. This was she in early post-op. This is another patient where we have just used TFL for the floor and ALT for the filler. So another gentleman, if you see in him, the maxillar defect is, it's more of a craniofacial defect, where even the frontal bone has been exposed and dura has been exposed, and you have to just line it. Now, if you observe here, I put this photo for one message that don't try to put too bulky a flap when orbit is excised, because it comes in way of even a spectacle mounted prosthesis. So put something which will take to the curve of the orbit. So this was one more patient where we used a DF, his thighs were very thin for the fill. Another opportunistic indication, very thin individual, see, we use the LD and serratus for filler. Now if you look at the literature, there is a lot of work by Peter Corderio of the MSKCC group, where he uses liberally non-vascularized bone grafts with soft tissue flaps. So mostly his choices are rectus or radius, and he uses them with various concepts, size and shapes of iliac crest bone grafts, mostly for the orbital floor, rarely for the alveolus also. But at the same time, there was a group in MSKCC who was using fibula for everything, the Hansono's group. Fine. So this is one patient where very thick thighs, orbital floor and medial wall also excised. So we planned a complex radial artery forearm flap and used iliac crest for the floor as well as the medial wall of the orbit. This was she at early post-op. This was she at 1 year post-radiation. All the deficiencies of soft tissue came out. She never agreed for a fat filler liposuction and lost to follow-up later. Another lady where we have used the DEP with iliac crest for the orbital floor. She had a peronia magna. We had started with a fibula, but then had a variation. So This was she at early follow-up, and in late follow-up she had an implant exposure, which is a recurring theme with this thing. So it comes to the next, the whole problem with the non-vascularized bone graft for the floor and soft tissue is that you give out all possibility of osseointegration, plus the cosmesis also is not great with the volume loss. So our go-to flap is often fibula for the alveolus defect, especially when it is reaching midline or crossing. The general rule is you use the ipsilateral pedicle so that it falls in the neck better, use the peroneal surface for fixation. In this way, the skin island falls in the oral cavity and is very naturally fills it. Now, if you look at all the elements what we need, fibula is amenable to all these things. We have a variety of osteotomies and planning you can do with it and achieve it. So this is when you need only an alveolus and palate, where the skin island can be used for palate and bone for the alveolus. Things get interesting when you have to reconstruct it with the orbital floor defect. So in the simplest format for the orbital floor and rim, you can use the distal part of the bone which will be vascularized and reach there. But then the compulsions of your perforator location and orientation come into play, and sometimes you have to use the proximal fibula based on the FHL, which sort of becomes a quasi-vascular supply to take it up. One argument is it doesn't match the shape of the floor, rightly so. So you have to turn and use the peroneal, which is the peroneal surface of fibula, which is the largest for the floor. Plus you can double barrel it based either on the distal vascularized end or on the FHL or as with a non-vascularized bone graft. Now sometimes the problem is there is resection goes into the frontozygomatic and zygomatic process, and you can't place your bone at the appropriate level. So the shape of the floor and level of placement is very important. Like in this case, I've added a small piece of non-vascularized bone graft for the frontozygomatic process. Second trick which comes into play is when you place the bone transversely, so is your skin paddle. So you need to cut the septum, preferably on one perforator, and orient it longitudinally, and then turn over the proximal part to be used as a filler and for softening all the contours over the bone. This can be done the other way around also, when you can use it for nasal lining, but I think this works better. If possible, you can generate a chimeric skin island for the nasal lining also. It's very important, but the vagaries of perforator distribution in the leg often don't allow you this. So this was one example where this paddle has been used. So the paddle the part of the bone which goes for the orbital floor can carry the perforator for the distal island. Now another trick is you can often take the perforator off bone in the fibula. So like here where the perforator was, that part of bone has been removed. So this thing can be done easily. A few case examples. So this was a young boy with I think a giant cell tumor, where we had put a fibula and a skin island. Small defect. He was a boy when he did it. He grew up, comes with a good mouth opening, refuses osseointegration every time. So another gentleman with type 2D defect, where again a fibula has been done with good cosmesis. This was a case of a melanoma, relatively poor prognosis with skin involvement also, but it was such a predominant central large defect that we chose to do a fibula here with a decent outcome. So now here's where things get complicated. Total maxillectomy 3B defect with an orbital floor defect. So here we have used the fibula for the arch as well as for the orbital floor, and the skin paddle has been used for palate and filler. So this is him 6 months post radiation. So this is a good outcome. It's not always so. So another patient with a orbital floor defect, where we use chimeric island for nasal lining, floor and central plus this segment. So this was him at 1 year. He had a facial palsy which recovered. Now sometimes, as I said, your defects come with an even more elements. Like here the patient had a marginal mandibulectomy and a buccal mucosa defect also. So we have double barreled for the floor. So the point here is that orbital floor defects are not a uniform entity. Sometimes you will have a small rent in the floor where probably you don't need to do anything. Sometimes the floor is removed but the periorbita is so well preserved, the periosteum, that whatever you do, it will do well. Sometimes the whole floor is gone, rim is preserved, or sometimes the rim floor is gone with lateral or medial wall. So you need to judge what exactly is the defect. This also inherently presents you with a challenge that whatever you do, given the convex nature, biconvex nature of rim and the floor, it's very difficult to replicate it with almost any biological tissue. And that's where the whole argument for meshes, implants, prefabricated implants come in. But all of them being non-vascularized and in radiation setting with whatever you do had this run the risk of exposure. So we have gone through these circles multiple times. We have switched from autologous to non-vascularized with cover, and still the answer is out there. So here he was fixed in the orbital floor and film. This is early follow-up, and this was him post-radiation at 6 months. So sometimes even the zygoma is excised, and in this case we had a non-vascularized bone components to orbital floor and this, and used for filler, and this was him post-radiation. This was one of the early cases which had a very large soft tissue defect, where we put a zygomatic component, one for nasal support, and joined all of them to form a square with chimeric skin islands. He did pretty decent, had implant exposure, but bone was viable. So we did a local flap and salvaged him. So now if you look at this gentleman, it looks like a fungating lesion, but I remember De Cruz sir talking this concept where there is no edema beyond the fungation. It's sort of a very localized disease. So even after excision, we did a big fibula with skin island, and he did exceptionally well. And he came after some years with this follow-up, and actually orbital floor position has remained except for the lip edema. Now sometimes primary reconstruction is not possible, it's preferred. So you get these patients with poor mouth opening. You need to first achieve basic form. So here we have just parked a large ALT, and that served the purpose. So this gentleman I showed yesterday also, we did a secondary fibula in him, very unsatisfied, went back to camouflage it with a scalp for the mustache. This case I showed in panel yesterday, real complex, one ALT with non-vascularized bone graft, another ALT for soft tissue, still didn't work. Finally we put a TDAP with skin island, TDAP skin island with an angle of scapula for the floor. It's holding till now, but he might just end up with a orbital exentration and an implant later. I think madam's talk is already starting here. There are complications galore in maxilla. Occasionally, if your vessels are poor or perforator, you have compulsions, you need vein grafts. Contour deformity often happens, you need to fat graft it. Lid, very sensitive organ. Whatever you do, sometimes it just goes into this edema and you can't find the end of it. Again, if you do anatomically everything correct, still you might have ectropion because of lid sensitivity. Then expose implants and bone with radiation. You might need a median forehead or a freaky flap later. Non-vascularized bone graft, I am not a big believer in it. I think it tends to come out sooner or later. Like in this young boy, where the eye stayed in position, but the bone graft came out. So we did a freaky flap later. Sometimes it looked good early, but radiation and gravity take their toll. So this was a patient who had a very atypical defect where we did a fibula, but probably a customized implant would have been better here. And very rarely you will have facial paralysis when you try to tunnel it into the neck pedicle and do use too much stretching. And finally, radiation never leaves us, especially the mid-phase defects are a topic in themselves and really complex to deal with, and poor etiologies of disease also. I'll just summarize with some lines I had written some time ago. Maxilla is not a reconstruction simple, many variables, scope for artwork ample. Every defect is different and three-dimensional. Standard works for most, some need unconventional. Obturator and prosthesis can best tackle defects small, but you need good bone and teeth to anchor it all. These defects small can also be served with flaps, muscle or cutaneous, saves the trouble of obturator and life will be long and joyous. When the defects are lateral, too large or bad disease, use a flap with lots of fat and volume with relative ease. Everything in between deserves a step more. Bone-based reconstruction gets fibula to the fore. Fibula can work wonders in some hands, call it magic or voodoo. Bone can make alveolus, orbital floor and zygoma too. FHL muscle need not be wasted. In cavities and dead space, it can be rested. Skin paddle can make palatal nasal lining, filler and skin if needed. It might require some good luck with perforators and skillful deed. Segmental periosteal supply and perforators to skin island are the basis. In this treacherous desert, fibula might just be the oasis. It's not with problems, I agree, some solvable if you foresee. Dystopia in ophthalmos, contour deformity can be avoided with some tricks. Ectropion, lid edema and radiations equally to skin get you the bricks. For maxilla, fibula and many options to use, adopt and nurture them like you use. Thank you.